Welcome! This explainer is designed for you, the IBCLC candidate preparing for the certification exam. We're going to cover a structured frameworks that will help you differentiate the common causes of infant gastrointestinal distress.
So, let's start with a very common clinical scenario. An effective consultation requires structured clinical reasoning, not just reacting to symptoms. And that's really the core competency we're going to focus on today.
Here's our agenda. We'll follow a logical path, starting with professional boundaries, then we'll differentiate the key conditions, identify important red flags, and synthesize all of this into a clinical algorithm. We'll wrap up with some high-yield points specifically for your exam.
Okay, first things first. Before we even begin to analyze pathologies, we have to clearly define our professional scope. This is a cornerstone of safe practice, and you can be sure the IBCLC exam tests this boundary. Remember, our role is not to diagnose medical conditions. Our role is to recognize clinical patterns, to identify red flags that absolutely warrant a medical evaluation, to optimize the mechanics of lactation and feeding, and of course, to refer appropriately. Our main goal here is to protect that breastfeeding dyad while always ensuring clinical safety.
Let us now discuss what is probably the most common area of clinical confusion, lactose. To get this right, you have to understand the underlying mechanism. It's essential for correct management.
It is absolutely critical to understand this. Primary congenital lactase deficiency is extremely rare. This is an autosomal recessive genetic condition, and it presents right from birth with severe, watery diarrhea and life-threatening dehydration. This is one of the very few absolute contraindications to breastfeeding.
So, the clinical features of true lactose intolerance are directly related to carbohydrate malabsorption. Basically, undigested lactose ferments in the gut, which produces gas and those characteristic acidic, watery stools. I want you to note the absence of systemic or allergic signs, things like blood in the stool or eczema. You won't see those here.
Now, let's examine the critical distinction between a true enzyme deficiency and what we call functional overload. This is a key concept for your IBCLC exam.
Here's the crucial point, and from an exam perspective, this distinction is key. Green, frothy stools in an infant who is thriving and gaining weight rapidly, that is most commonly due to functional lactose overload, which is often from maternal oversupply. The infant's lactase enzyme capacity is simply overwhelmed by the volume of lactose. This means it's a feeding management issue, not a true enzyme deficiency.
The next condition to differentiate is cow's milk protein allergy, or CMPA. Now, here the underlying mechanism shifts. We're moving away from carbohydrate digestion and into an immune-mediated inflammatory response.
The most common way this presents in exclusively breastfed infants is something called allergic proctocolitis. This is a delayed, non-IgE-mediated immune response. What happens is trace bovine proteins from the maternal diet, like casein and beta-lactoglobulin, pass into the breast milk and cause localized inflammation in the infant's distal colon.
Now, while you hear CMPA discussed frequently in clinical practice, it's really important to remember its actual incidence in the exclusively breastfed population is quite low. It's estimated at only about 0.5%.
The clinical features really reflect this delayed gastrointestinal inflammation. Key signs include visible streaks of blood or mucus in the stool, often paired with persistent irritability or maybe some eczema. Critically, the infant is generally well-appearing, and that helps us differentiate it from a more acute illness.
Let's examine this more closely. The presence of blood in the stool is a significant finding. It requires a very structured assessment for red flags before you even consider CMPA.
So, before attributing blood in the stool to an allergy, you must first rule out more acute conditions. This is a crucial safety step and, frankly, a real test of sound clinical judgment.
An infant who presents with blood in the stool alongside any signs of systemic illness, we're talking fever, lethargy, acute onset vomiting, or any signs of dehydration, that infant must be referred immediately for medical evaluation. These are clear red flags for a possible infective colitis.
Now contrast that with reflux. It's vital to distinguish physiologic gastroesophageal reflux, or GER, from gastroesophageal reflux disease, or GERD. Physiologic GER is a common developmental issue. It's characterized by that effortless regurgitation in a thriving infant.
Pathologic GERD, on the other hand, is a disease state. It comes with complications like poor weight gain or feeding refusal, and that requires medical management.
We'll now synthesize all of this information into a structured clinical reasoning tool, one that you can apply both in your practice and on your exam.
This 5-step process gives you a logical clinical pathway. Step 1 is always to assess for red flags. If they're present, you refer immediately for medical evaluation. Step 2 is to conduct a thorough feeding assessment to optimize latch and milk transfer. If symptoms persist, then Step 3 is to analyze the stool for blood or mucus. Step 4 involves assessing the spit-ups to differentiate physiologic from pathologic reflux. And finally, Step 5 is to analyze those green stools, differentiating overload from true intolerance.
So, if red flags are absent and the breastfeeding mechanics have been optimized, the characteristics of the stool will guide your next step. For a well-appearing infant who has blood or mucus in the stool, it is appropriate to consider allergic proctocolitis and to support the parent in a 2 to 4 week maternal dairy elimination trial.
Let us conclude with the most high-yield points for your examination. We'll synthesize these critical distinctions right now.
These are the points the IBCLC exam will expect you to understand and apply. First, primary congenital lactose intolerance is extremely rare. Second, physiologic GER is common, while CMPA in exclusively breastfed infants is uncommon. Third, blood in the stool requires assessment for systemic illness first before considering allergy. Fourth, lactose overload is a feeding management issue. And fundamentally, IBCLCs must practice within their scope and remember that the underlying mechanism determines the management pathway.
Ultimately, our goal is to apply a thoughtful, structured assessment. This approach avoids unnecessary interventions, it ensures infant safety, and it protects the breastfeeding relationship.